Morning guys, Patriot Medic here. Hopefully you can hear me okay. I want to do a video today real quick about tourniquets and what I feel is them being overemphasized in our trauma kits and our bug out kits, whatever you're going to carry for you when the proverbial crap hits the fan. I've seen a lot of videos where guys talking about, oh, I've got my combat action tourniquet, I've got this, I've got that, and that's wonderful, that's great. It's a tool, they are effective. We'll give a little bit of history about the tourniquet. From what I understand, they've been used since like the 1900s. They fell out of favor, they came back into favor after World War I, they fell out of favor again, it's gone back and forth and back and forth. And ideally, today's latest and greatest and well-known commercially available tourniquets are what's called the Combat Action Tourniquet, or the CAT tourniquet. And that device really saw a lot of use during the wars in Afghanistan and Iraq. And when soldiers or our men and women who are in service would be injured, they would either self-apply the tourniquet, or a combat medic or a parajumper or somebody who would come in there and render aid was able to put this device on quickly and stop the the bleeding, the profuse bleeding, and move on to either fight or treat other people that need to be treated on the battlefield. And they work great for that. It's a wonderful solution. They've been proven. I'm not going to go through all the data. You can look that up if you want to on your own. What I am going to address, though, is one key part that I think a lot of people are leaving out of that equation is that, okay, once you put the tourniquet on, in the battlefield setting, when a soldier or a serviceman or woman gets that tourniquet placed, they're going to be in definitive care within roughly 2 to 3 hours max, okay? And what I mean by definitive care is a trauma surgeon, okay? Somebody who's going to render professional, doctor-level care, whether that be vascular repair, whether it be vascular surgery. It may mean amputation of the limb. So, relying on a tourniquet for the only way to kind of control limb bleeding, or overemphasizing the importance of a tourniquet, I think is really a flawed ideology, and we should move away from that. There are a lot of reasons why tourniquets are good. We just covered some of those. And there's also some reasons why tourniquets are bad and should not be, or at the very least, whoever is doing the first aid, whoever's rendering care, needs to keep this in mind, that you can have all the tools you want to in your tool bag. You can have tourniquets in your tool bag. If you don't practice and train on that skill to properly apply that tourniquet, the odds of you doing it correctly are very slim, right around 30% actually. I could post a study that was done in 2015 of a group of guys going through basic training, and they took a sample of the guys going through basic training at the beginning of basic training, said, here's a combat action tourniquet, I want you to put it on, and give a quick little brief display. Everybody ran around and did it to their buddies, and now did it to me and did it to you, and they took an they evaluated the efficacy or the effectiveness of that. They used what's called an ultrasonic Doppler to measure the arterial blood flow distal to the tourniquet. So I say they put it here, mid arm, and we're going to check around the AC or down here by the radial, and see if we have a blood pressure or see if we have a pulse. Initially, during that first sample, don't quote me on this, but I want to say about 30% of the people put it on correctly. They took another sample about halfway through basic training, and that number had gone up to about 50%. At the conclusion of basic training, where they had emphasized the use of this self-rescue device, this self-application of this combat action tourniquet, the efficacy was still around 70%. Now don't quote me on that, I could be wrong. I'm going to quote the details, but my point is, even with people who spent dedicated time, day after day after day after day after day after day, being taught and having this beat into their head, still had difficulty doing it in times of stress. So for the layperson, for the prepper, for whoever is going to, pack a trauma kit and keep it in your car, practice that tool. It's an important tool. It's a good tool to have. Practice makes perfect, and that's true. Okay? So now that we've covered the tourniquets, kind of that, you can put the tourniquet on incorrectly, and what the study found was, I'll read a little bit of this, most of the time it was put on incorrectly. And actually, you know what, let's talk a little bit about how a tourniquet functions for those who may not know. And you'll have to, I apologize here for my horrible, this is an arm, by the way. 1, 2, 3, 4. Okay, so this would be, like if you're wearing a watch, this would be the watch face of your arm. And this would be going up into your shoulder, and here would be your torso, okay, of the person. And let's say someone is experiencing an injury right here. They got shot. Okay, they got shot through and through, straight through. There's probably some damage to the bone inside. There's probably some humeral involvement, maybe a shattering of the elbow, something. It doesn't matter. What I'm trying to say is there is a blood vessel that runs from the heart down through here, and then it kind of splits off into smaller ones around your wrist. And without getting into too much detail, we'll just call this A for artery. Okay, it's actually the brachial artery, and it traverses the inside of your arm right here. And we also have smaller, make these green, blood vessels that return blood back to the heart and other organs and tissues along the way, are perfused through the capillary beds and so on and so forth. And without going into too much anatomy and physiology, let's stay focused on this. Now, let's say we take a cutaway section of this and we act like we're going to look at it from this point of view. Like I'm going to cut my arm and I'm going to look down it like a pipe, okay? So we're going to bring it over here, and this is what we're going to see, okay? So here's your arm. You've got some muscle tissue. You've got subcutaneous fat tissue, and you've got veins and stuff in here. You got veins. You got little capillaries off on the outside, and down towards the core, near the bone, you have a nice big fat juicy artery, okay? And 9 times out of 10, if you're putting a tourniquet on somebody, it's because they have arterial bleeding involved. And typical direct or indirect pressure is not sufficient enough to stop that hemorrhage, okay? So my point with this is we come along and we say, listen, we're going to put a tourniquet on here, and we're going to put it around the circumference of the extremity. And I was trying to find an example here of what I could use. But anyways, we're going to come along here and we're going to put a tourniquet around the extremity, around the around, like that. And we're going to tighten it down and tighten it down and tighten it down. And we're going to squeeze this down with the idea of stopping the blood flow here. Stopping the blood by coming out by applying the tourniquet here. Okay? We're going to go up proximal to the injury. Proximal is closer to the body. Cut it off there and hopefully stop the bleeding. Well, in perfect world, it works out that way, and they're effective. Like I said, they're awesome tools. They really are. And I wish we would have got them in EMS earlier. But my point with this is, I made a little drink of coffee here. If you haven't noticed, I love coffee, by the way. Love coffee. But what I'm trying to say is, when we go to those numbers, those 30s, 50s, and 60% effective rate, a lot of what they found in that study was when they put this tourniquet around the arm and tightened it down, first of all, it wasn't tight enough to occlude or stop the blood flow by pressure, by cutting off that artery, okay? And what they were finding was that they were pushing around here and they were occluding the veins, okay? Because you're going to include the veins first. They're closer to the skin. They're getting more force applied to them than the inside, because the inside is insulated for a reason. It's an artery. It's a vital functionality of that extremity. It's being protected by natural, like I said, muscle tissue. It's got some bone there. It's got all sorts of stuff. So it's being naturally shielded and kept on the inside of our arm, close to our body, close to our core. So if we do get injured, we can that's the opportunity of our body. So, well, what happens when? So, who cares, right? Whatever. We put it on. At least we stop some of the blood, right? Well, maybe. The problem is if the person who, let's say this is put on incorrectly, and we happen to cut off the blood flow to the veins and not the artery, sure, you may slow that bleeding down. Okay, you may. What's most likely going to happen is what's called a paroxysmal change, is the bleeding is going to increase. Okay? Because this is a two-way street. Remember that. Blood is going out to the extremity and blood is coming back from the extremity. So if you're not significantly stopping the blood flow to the extremity, but you have effectively stopped the blood, the venous return from the extremity, it's going to pool. Okay? All that venous blood is going to pool in here. All down in here, all this stuff's going to get full of oxygen poor. The blood is not being, the blood, you're talking about, you could have compartment syndrome develop with this. If you've ever taken any advanced EMT courses, or if you're a nurse and you work in the ER, or you know what I'm talking about when we say crush injuries and prolonged injury to an extremity being without circulation, okay, and that causes a lot of damage when that's not done correctly, okay, because you're still going to have the arteries still going to be putting the blood out, and you've probably damaged nerve endings and all sorts of shit in the arm or the leg or wherever the extremity is. So to recap, I'm saying, tourniquets, yes, they're important. They're a good tool. Keep them. Use them. I'm all for it. I have a couple tourniquets. I just should have grabbed one when I was doing the video, but it's upstairs in my kit. But the main point of this is skills, practice, train. Do it freaking correctly, because you probably are doing it wrong. And if you think, oh, I got it, it's no problem. Well, as a paramedic with 8 years in EMS, okay, who's worked pre-hospital and in-hospital and trauma center, you're doing it wrong, okay? I train on this every month. We go through and train on this and keep it fresh in our minds. When we train EMT students to use this, I tell them, take it home, put it on yourself, put it on your mom, dad, your girlfriend, whatever, your boyfriend, whatever you're with. Practice, 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 practice. Okay? Close your eyes and do it. Okay? Try doing it in the back seat of a car. You know what I mean? Try putting the application on in the back seat of a car, or the front seat of a car, or in the snow, or when it's cold, when it's raining, or it's dark, and it's. So you get the point. You need to practice. So much more emphasis needs to be put on proper assessment skills and proper application of those skills than the tools themselves. Okay? So, like I said, I'll link in the description here. Put a link in the description of what study that I am referencing, but I'm also going to read a little bit here. This is from Dr. Reed Smith, and this is from the Emergency Medical Journal. And this is in particular, this is an application to active shooter events. And what he is referencing is wounding in active shooter events differs from combat and may require different therapeutic emphasis. Although tourniquets and external hemorrhage control techniques hold value, their role in active shooter events may be overemphasized as a means to decrease a fatality. The focus on external hemorrhage is important, but it's not enough. And he goes on to further say, additional interventions could be taught for every step in the chain of contact, from citizen, the layperson, to the trauma surgeon at the definitive care. These could have greater benefit for teachers, for instance, could be taught to roll victims on their side, clear out their mouths and keep the airway open, and then keep the patient warm to prevent hypothermia until help arrives. Police could learn to insert nasal airways and occlude sucking chest wounds before fire and EMS arrive. And once fire and EMS arrive, they can start the initial damage control. His point with this is everything needs to build on the previous step, okay? And if you're watching this video and you're interested in learning basic medical skills, you need to learn those basic medical skills, just like he said, just like I'm saying. You need to be able to assess the patient, figure out what are you capable of doing for that patient, rendering aid that's within your comfort zone, so to speak, so you don't harm the patient further, and then being able to keep that patient stable and warm enough until help arrives or until you can find someone who has a greater scope of practice than you. Okay? So, like I said, I'll link that description in there, and I really want you guys to check this out. I'm not saying tourniquets are bad. I'm not saying any of that stuff, so please don't misunderstand me. What I am saying is that they have a purpose, they have a place, but that purpose and place is not everywhere all the time, okay? So, thanks for watching. This is the Patriot Medic, and look forward to seeing a couple more of my videos. If here in a little bit, I'll give you guys some more stuff. We're going to go over a lot more of what's in that article, as well as some other articles. We're going to address the sucking chest wound he mentioned, something that should be addressed way before we even talk about needle decompression, but we'll get there, okay? Once again, this is the Patriot Medic. Thanks for watching, and remember, keep it simple.